After a short introduction, I will speak about TME targets, then clinical aspect, and then conclusion. I precise not having any conflict of interest on this particular topic. So, why look beyond FAPI? FAPI represents a genuine paradigm shift by enabling stromal imaging with high tumor to background ratio across a wide range of tumor types. By targeting cancer-associated fibroblasts, FAPI challenges the tumor-centric dogma and demonstrated that the clinical value of microenvironment imaging. However, limitations have rapidly emerged. CAFs are biologically heterogeneous. FAPI uptake is observed in benign fibrosis and inflammatory condition, and diagnostic performance has proven variable across tumor entities and by patients. These observations underline a central message. FAPI opened the door, but the tumor microenvironment is far more complex, dynamic, and target-rich. As said, the tumor microenvironment is a complex, dynamic ecosystem surrounding cancer cells composed of non-malignant cells like fibroblasts, immune cells, pericytes, blood vessels, and extracellular matrix. It is characterized by hypoxia, acidosis, and high interstitial pressure. The TME is an active and dynamic ecosystem that promotes tumor growth, invasion, metastasis, immune escape, and resistance to therapy, while facilitating local invasion and metastatic dissemination. Rather than being a passive scaffold, the TME actively influences therapeutic response and clinical outcomes. Cancer cells change their surrounding environment, influencing nearby normal cells and the extracellular matrix. In turn, this microenvironment feeds back to modify cancer cell metabolism and signaling. Let's look at the cellular and non-cellular components of TME for cancer targeting. In most solid tumor, endothelial cells build up the inner layer of the blood vessels as part of the growing tumor. Cancer-associated fibroblasts in the immediate vicinity of cancers play an important role in the tumorigenesis in various physiochemical ways by reducing apoptosis and improving the proliferation, migration, and viability of cancer cells. Based on their origin and half-life, tumor-associated macrophages are long-living resident macrophage and short-lived circulating monocytes. Extracellular matrix form the scaffold of tissue and is composed of fibrous protein, collagen, elastin, hyaluronic acid, and glycoprotein. Then we have the circulating tumor cells, then the exosomes that are nanoparticles constantly secreted into the extracellular space. They facilitate specific cell-cell interaction and stimulate severe signaling pathways. We have also the circulating free DNA, and then the apoptotic bodies that are extracellular vesicles that are released absolutely from the cells in apoptosis. Then the pericytes that are multifunctional cells that envelop the surface of endothelial cells. Finally, of course, the TME is characterized by hypoxia and acidity that can be targeted. Let's look now at the cellular component of the TME as imaging targets. Beyond FAP, the alternative markers such as platelet-derived growth factor receptor beta, integrins, and extracellular matrix proteins like tenascin C provide complementary biological information. Multi-CAF phenotyping may better capture stromal diversity and explain variable responsible to FAPI-based approach. The immune landscape of the TME is dominated by immunosuppressive population, particularly tumor-associated macrophage. Imaging of macrophage markers such as CD163 and CD206 and translocator protein enables non-invasive assessment of immune suppression. Beyond programmed cell death protein 1, ligand 1, immune checkpoints including lymphocyte activation gene 3, T-cell immunoglobulin and mucin domain containing protein 3, and T-cell immunoreceptor with Ig and ITI domains. They represent emerging imaging targets to distinguish immune exhaustion from immune activation. Angiogenesis remains a hallmark of cancer, with VEGF and VEGFR signaling and integrin expression reflecting vascular remodeling. LRIG-GD-based tracers have long demonstrated the feasibility of imaging angiogenesis, while vascular normalization is increasingly recognized as a measurable therapeutic endpoint rather than a static feature. The cellular transmembrane integrin receptor recognizes the arginine glycine aspartate (RGD) peptide. Preclinical studies using different radio tracers, like for instance gallium-labeled cyclic RGD nanopeptides, showing a nice uptake of the tumor, or in this human study, 18F galacto-RGD PET in an invasive breast cancer. Again, preclinical study, tenascin C, showing the uptake of the tumor and the decrease in time. Immune microenvironment. Let's look at mannose receptor, CD206. The study from Gondry presents the case of two patients, respectively patient 1, A to C, and patient 2, D to F, both with non-small cell lung carcinoma and residual lesion in the lung region. This during the treatment. In patient 2, there is a clear uptake of gallium nota anti-CD206 as the antibody in the lung lesion. Image DE versus AB, the first patient. 15 weeks after the study, fluorine FDG confirmed the complete remission in patient 1, image C, and a persistent disease in patient 2, image F. Let's now analyze the TSTO imaging. The study from Albert present translocator protein PET with 18F GE180 in 2 glioblastoma patients before hypofractionated radiotherapy and temozolomide chemotherapy. The first line A, there is a 76-year-old male patient with left precentral glioblastoma. The tumoral uptake was high, SUV max 2.4, and the survival was low, short, overall survival 4.5 months. In line B, we have a 71-year-old female patient with left post-central parietal glioblastoma. In this case, the tumoral uptake was low, SUV max 1.8, and survival was long, 25.8 months. In this preclinical study, we used SPECT-CT with technetium labeled lymphocyte activation gene 3. We have an example of 2 mice, one treated with tumor at day 11 and day 17, and the control at day 70.